Um, where did it go? Wait, where is it? Okay, hold on. Oh, right. It's back here. All right. So,
Perfect. Yep, that's coming through.
Still getting shunted.
okay. And then, okay. So, great.
Oh, this looks awesome.
Wow, fabulous.
Okay, so, okay. So I guess that's all working then. I'll
Perfect.
stop the share. And I learned something new. That's exciting. A new button on Zoom I didn't know existed before.
Yeah, there's lots of surprising features that are great.
Yeah, yeah.
Oh, that was way more HD than we were used to seeing in person too. That's awesome.
Yeah, it
Yeah,
looks great.
things like this are going to be things that I think people might get more out of
What program is it?
in this forum.
What program was that, Barbara?
That was. Oh, now I'm myself twice.
Uh,
Let me see.
it's probably because you're going through somebody else's doesn't have their headphones on, so it's
Oh, okay.
the
So that was, I'm just using Google Slides, but then those were some examples of stroboscopy that were just taken off of the strobe system and put into a video file.
Good fonts, good everything, good layout. Well done.
Jeannie. Let's just quickly just test to make sure that your audio is good to go for when you're talking.
Hey Billy, how am I doing? Hello, good morning. Nice to see everybody.
Yep, that sounds great. Awesome.
Hi,
How
Barb,
exciting.
joining us.
Yeah, this is very exciting.
Yeah, well, we had a really nice day yesterday. We had
Mm-hmm.
nice responses, so we're excited.
Great.
Um,
How many people are registered for this level anyway?
One is 238 people,
That's great.
and
Wow.
all of them are in real time. Some of them are delayed because they're all over the planet. I mean, really all over the planet.
Yeah.
And so the West Coast people are 3 hours behind.
Mm-hmm.
No, she didn't hear me. Uh, I said, you guys in the West Coast people are 3 hours behind.
Yeah, I'm not awake yet, Jeannie.
Neither am I.
Yes, I don't blame you. If it was me, I would feel the same way. Um, I have to go get something. I'll be back.
This morning when I was up at 4:15, I'm looking at my clock saying, "Oh my gosh, for Billy and Leishan and Craig, it's only like 1:15. They're probably just going to bed and I'm already getting up."
Oh no.
You get up at 4:15?
5 o'clock.
Oh,
I have a commitment I have to do at 5 o'clock in the morning. So it's like,
oh, that's
so,
not your regular wake up time.
yes. Yeah.
Oh my gosh.
That's nuts.
So that's why last night at night, after I got off of my office hour thing and then answered some emails, and it's like Meredith is like, "Who can put these links in?" And I'm like, "I can't. I just my brain is mush." I shut
Yeah.
the lid and I went to bed.
Well, you know what? I ended office hours. Craig and I ended office hours. What's it like 10 p.m. and I was up at 5:30 so I could be here by 7:30.
Right. Right.
Oh, no, I was up at 6. But
Yeah.
yeah. But
I
I
have
got
a
up at
question.
6:45.
late evening office hours were fun.
So we
Yeah.
have to figure out what we're going to do with that one international breakout group that's going to overlap with the changed time that we have now for that breakout on our day 3.
Can you say
Okay.
that again?
So on Monday,
Right. On Monday, we moved our breakup here. I'm seeing now. I'm doing it, Benjamin. The breakout we moved to 11:45, and that international group is supposed to start at 12 noon on Monday.
okay. Meredith has been made aware of that, and Trinice is going to talk to that group today and tell them that they need to sign up for a different slot.
Okay.
And the same thing is happening with the 4 people that I'm seeing today. I will be telling them. So Trinice is probably no. No, it's not. Sorry, my brain is trying to convert 3 hours. No, so when Trinice sees them, she will tell them today.
When Michelle and I were trying to figure all of this out and then assigning the faculty for the regular breakouts to make sure that we didn't have one person doing two, which we ended up doing anyway. But, our brains were like going, I don't know, how do we do this? And it is crazy. But one thing that we said is we're trying to be all things for all people for this.
I don't know. I'll have to see.
Institute right now.
I move around back
And then cross-referencing who's presenting at the same time.
Right.
Yeah.
And who has office hours and who was understudy.
Yeah.
Speaking of all things for all people, I did make a note of it, but we have a by her admission or her description, a very pregnant woman
I didn't make
who
it.
is basically concerned about, hormonal shifts and how that affects head and all that stuff. So it's kind of a unique thing. I don't know where that would fit. I mean, it could fit perfectly well in terms of what we were doing right now in terms of head and what do you do when it's not responding the way that you want, and like we did good stuff, but because it's a topic,
X out of
it's
it.
a bigger topic that it might be worth talking about.
That was gonna. This is fine. All right. Betsy,
Yes, I am here.
will you put Barbara's little picture and bio up for me?
Yes. Do you want it now or wait until we start?
I don't know. I guess I don't know. I'll guess wait until just before.
Okay. Yeah. So when you say hello to everybody and welcome, and then I'll put it on.
Okay. All right. That's good.
Now, I briefly turned on my air conditioner because it's like 97 here today outside. Are you hearing the whooshing? Should I turn that off before I start?
I'm not hearing anything.
I hear
think
just a
it's-
little bit.
It's not interfering with
I hear mine.
to hear you.
Okay.
I hear it a little bit, and it gets louder if you're quiet.
Okay. So like if I'm talking right now, that's muted a little bit more because I can turn it off for the.
Billy, what happens if she enables?
I'll turn it off right before I start.
If she enables the noise suppression.
So that's already done because we did that a couple of weeks ago when we went over the audio stuff. So that should be set up already.
Actually, what Craig is saying is we should maybe reverse that for her background noise.
Yes.
'Cause she
think
wants-
I
so,
can
because
turn it off. It's fine. I'll just let it cool down until we're ready to begin, and then I'll turn it off. And
No, I don't want you to go do this whole thing and be sweating and miserable. It's not so bad you can't tolerate it. Do what
Why
Jeff.
don't we try enabling the noise suppression? Turn the noise
All right.
suppression on.
I'll need to remember to unenable it afterwards.
That's okay. So, Barbara, if you go bottom left next to the mute button, you'll see a little arrow. Click on that arrow.
Oh, yep. I can do the suppressed background noise. I'll
Yeah.
do it auto. How's that?
You'll also need to turn off original sound.
Yeah.
I'll need to what?
So once you're back into the main room, up in the top left, does it say turn on original sound or turn off original sound? What does the button
Turn
say?
off original sound.
So just click on that once.
Okay.
There we
All
go.
right. How's this now?
That's good. The background
Better?
noises.
Okay.
Yep.
All right. Now I have to remember to reverse that for when I'm working with people.
Can I just say one thing for the breakout faculty? Is everyone clear about what breakout group you're leading for the first breakout, how you get to your meeting, and where you input the information, where you have the list of participants, the spreadsheet? Is everyone clear about that? Or let me
Yes.
put it this way, is anyone not clear?
Yes.
I just want to confirm, like, we're just accessing it through the link that Billy sent, our breakout link.
To
slash
get
office
in, you
hours.
just log in. You can go into your Zoom and just click start, and anything that has to do with any faculty individually for your breakouts, office hours, anything is all done through there.
I have everything. Betsy sent this great clear email with all the links. What I don't have is the spreadsheet, and it doesn't come up in my Google link, my Google Docs. I don't know why.
I'll send it to you again.
Thank you.
I'll just email it to you. But you know what I'm going to do? That I just printed out the one with all the groups, and I think when I'm working with people, I'm going to scribble on here, and then later I'll transfer it into the spreadsheet.
Okay.
Hmm.
But Betsy, that was super clear. That was so helpful, that extra one you sent.
Mm-hmm.
Thank you. Thank you. Thank you. Thank you. Thank you.
Kate, unmute yourself, Kate.
Question, well, how do we get the sheet that we've commented on to the next person?
Same sheet. It's the same sheet. Everyone has access to it at the same time.
Thanks.
All right, 2 minutes.
Now this feels like television, you know?
Don't
Live TV.
A little bit of time at the end of your talk for questions. We are going to collect them as they come in, and then Billy will, or I don't know if it's maybe Michelle.
Be me.
Michelle will go through them so that whatever redundancies we have, we can eliminate. And, you know, questions that are pertinent, then she can feed those to you.
Sure, and that, because that seemed to work really well for the belting webinars you did.
Yeah.
Everything's nice and organized and everything got addressed.
Yeah, it's actually useful because it lets you kind of pre-screen the questions, which is a good thing. You know, you don't have to answer frivolous things. I think that's good.
All right. For backup recordings today, Amanda or Jeff, are either of you good to do that? Yeah.
I can keep doing it. That's fine with me.
Awesome, Amanda. I'm going to click the allow record
You saw that I've
button.
been uploading them, right?
Yeah, thank you. So far we haven't needed them, which is great, but just allow record.
Amanda, you need to do a morning radio show. You're all set up.
All right.
This is Amanda Chmela in the morning.
I have no idea what I'll talk to you about.
All right, I'm going to let everybody in.
Okay.
If all faculty could mute themselves.
Why is there a slide up? Okay.
That's Craig's background.
Oh.
All right. Good morning, everyone. Or afternoon or evening, depending where you are. Just going to give everyone a second to get in. I see there are still some people in the waiting room. All right. It looks like, one more person in our waiting room. Oh, and Meredith, fabulous. All right. Welcome everybody to Level 1, Day 2. I'm just going to give a very quick overview of Zoom again because I know there are some people who were not here at the beginning yesterday. So at the very bottom of your screen, you're going to see the chat button. I'm going to say hello in the chat right now. We just ask that you save your comments and thoughts about what's going on for the Facebook group. And in the chat, just put your questions there so that we make sure we don't miss any important questions. This morning is going to be really fantastic, but I'm going to pass it off to Jeannie.
Good morning, afternoon, evening, everybody. We're so happy that you've come back to join us on day 2 of Level 1. I just have a couple quick things to say before we start with our first guest expert. I want to remind everybody that we're looking for somebody in Level 3 who cannot match pitch, who is willing to be a guinea pig for my work with them in the afternoon. I think it's 1:15. But if you have somebody that is a person who cannot sing on pitch, email one of us. You can email me or Michelle or Betsy. Let us know so we can work that out. We are counting on you to find somebody that is a willing subject. The second thing I wanted to talk about is through the lecture we have a break, and then after the break, you're going to get your instructions to go to the breakout. And the first breakout is going to be 1 hour long. And you will have, each group will have a teacher. The group will stay together, but the teacher will change over the course of the institute. And they'll take it through from there, and you'll have fun with that. It's exciting.
So Jeannie, I just want to mention for that particular segment, everybody will have to log into the large group with that link to start. And then we'll leave that meeting, and then you'll have to click on your individual breakout group link to go into the breakout itself.
Okay, we'll tell them that again just before we go. Okay, so you can navigate on the site. When I first started my investigations in voice science, I was struck by the difference between singing pedagogy information and voice science information as applied to the clinical work that a speech pathologist does in concert with the medical profession and the laryngologists. And I felt that there was a huge, big gaping hole in our profession, the teaching profession, in that we did not understand how to avail ourselves of the tremendous resources we have in our speech pathology colleagues, especially those who are sometimes also singers. And I really wanted to bring this information to the participants of this course because we are not speech pathologists, underline exclamation point, unless you are, and go get a piece of paper that says so. If you had to find somebody who has knowledge, expertise, and experience, who can talk to you intelligently in a way that you could utilize, you'd have to do a lot of work. And then having a lecture aimed at you as a singing teacher would be another specialty. So I'm telling you this because I really want you to feel very, 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 very grateful and fortunate to have the opportunity to listen to a lecture like the one you're going to get now, because where are you going to get that? You can't go to the local corner and buy one, right? So I would like to introduce our guest. Betsy, would you bring that slide up? We are honored to have Barbara Wilson Arbolito, who has her degree in speech pathology, and the CCC means Certificate of Clinical Competence. It's a test that speech pathologists have to take. And she is also a singer. I think, if I remember correctly, she told me she's a rocker. So that's cool. And she works in Massachusetts, in Boston, in the Beth Israel Deaconess Medical Center. And prior to that, I think, if I remember correctly, she was at Harvard. So you're really lucky to have somebody with her expertise and her energy to help you understand her profession and how her profession and our profession can work together to support our students. So I thank you and I welcome you, Barbara Wilson Arbolito.
Thank you very much. I'm really excited to be here. I'm excited to be asked to be here. I think my first introductions to somatic voice work were probably back in 2010. I think I took a level 1 out in UMass Dartmouth or something, and then like the next year I came out and did 2 and 3 in Virginia. And you know, as Jeannie mentioned, I've always been a rock singer, and so I think, you know, growing up in the you know, in the 80s, there just wasn't a voice pedagogy, or maybe there was because Jeannie was out there, but I didn't know about it, and neither did any of my teachers. And so, you know, I think it's been so important to have the development of different approaches to pedagogy that can come from a without that aesthetic bias, to say that, you know, we can have these different functions of the voice system and that we can use our voice in many different ways and still support healthy voice use. Now, you know, it's true that probably my frustration with not being able to find what I thought was relevant instruction probably led me in the direction of being a teacher and a voice specialized speech pathologist. So perhaps I have that to be grateful for. But I'm really excited, like I said, to be here today and to talk to you about vocal health in general and some of the principles of it and how we think about it. I'm going to share my screen out for some slides. Okay, now I just want to double check, are you guys seeing the slides? And
Yep, we can see your slides. This is great.
awesome. Okay, because on the Zoom screen, I don't see them. I see them on my other monitor over here. Okay, so today, we already heard about me. I'm going to start off with something that's really important to me, which is the holistic nature of voice care. Then talk about some basic elements of voice care. Talk about vocal load, in particular, a new paper that I'm really excited about that breaks the principles of vocal load and vocal fatigue down into sort of a slightly different way than it has been conceptualized before. How and when to seek medical care and what happens during the voice evaluation on the medical side. I'd like to pass through what's the deal with straws, I say, because, you know, they've become really popular. And I just wanted to make sure people understand the scientific principle, basically, of what's going on behind that. And at the very end, of course, we're all dealing with COVID-19, and there are some specific issues that have come up in regard to laryngeal health, respiratory health, the aftermath of people who have had the disease that I just want to review before we're done, and then take some questions at the end. So we'll get started. Like I said, the holistic nature of voice care is really important to me, because what we have to recognize is that even though we're singers and singing teachers, this is only one of the roles we play in our life. Our voice and our voice care exists within the context of an entire human life. You may be a parent, a teacher, a sports fan, a marathon runner. You might have physical or mental health challenges, and every single part of you comes together and informs how you move through the world, including how you use and how you take care of your voice. And so I feel like it, even though it seems obvious when you say it out loud, that too many times I've seen people approach voice care as if someone should feel like caring for their voice is the only thing they're thinking about in their lives, and they put their 100% of their attention into that, sort of putting any other considerations aside. And that's just not how human beings work. So another misunderstanding that I see a lot when it comes to vocal care is that I often see that people get a little superstitious about it, that they feel like if I just do my perfect voice care, I am never going to have a voice disorder, I am never going to have a problem, I'm never going to have strain. And then unfortunately, conversely, what happens is that then people start becoming really judgmental of others that they encounter. So, you know, even in general areas of healthcare, like if only he hadn't smoked, he would have gotten cancer. If only she'd exercised more, she wouldn't have gotten diabetes. And it's only a small step from there. If only they hadn't had a margarita during their show, they wouldn't have hemorrhaged. You know, if only they'd stopped cheering at their kid's soccer game, they wouldn't have gotten nodules. And the truth of the matter is there is not a one-to-one relationship of if you do this, then this is the vocal consequence. There's a lot of variability in terms of you know, people's voice mechanism and all of the different aspects of their life that are combining. So I just want to reinforce that everybody, or you know, anybody can have a voice injury. No matter how much you take care of yourself, it can happen. And I don't say that to scare anybody, but what I do want to do is really make sure that, first of all, that you don't get really like conceited about when you encounter people who have had a voice injury and start trying to brainstorm on all the things they could have done to prevent it, but also to not blame yourself and not have shame if something happens to you. I have seen many singing teachers in my clinic. It's in fact one of my favorite things to do because we can kind of geek out together about learning some voice science as they're having their voice therapy. But getting a voice injury does not mean that you're bad or that you've even necessarily done something terribly wrong. We can't always predict who's going to have a voice injury. There's all these individual variables. And so one story I really like to tell people about is one that I encountered. It was probably 12 or 13 years ago. There was a woman whose profession was as a PR representative, but she was between jobs at the time. Now, I am a person who believes what the patient tells me in general. And from her voice history, it didn't sound like she was using her voice strenuously enough to account for the enormous hemorrhage, bilateral, meaning both sides of the vocal folds were just engulfed in blood and nodular changes. And, I believed her, but her doctors, in rounds, not with the patient in the room, were saying, well, there must be something she is not telling you. Which I think is really unfair because while I always try to prod to see if I can get a different answer, she really seemed to be being upfront about this. So massive vocal fold hemorrhage is one of those times when we still will prescribe strict voice rest for about a week or so, which she did. She came back. Her vocal folds were pearly white. Her body had cleared all the blood away, and we were really excited and ready to start therapy. But I never got to have therapy with her because a few days later, I got the notification in our medical record that she had been admitted to the hospital. I said, oh no, what happened? And I clicked to see why she'd been admitted to the hospital, and she'd been admitted to the hospital with admitting diagnosis of organ donor. And what that means is that she was already brain dead before she got to the hospital. She had had a massive brain bleed. The vocal fold hemorrhage we saw was indicative of something that was going wrong with her blood clotting mechanism systemically in her body, from which she passed. So again, that has only ever happened once in my career, but it sticks with me because we have to believe what people are saying. And there are all kinds of things that can impact what happens. She had a vocal fold hemorrhage, not because she was abusing her voice like the doctors were accusing her of, but because her blood clotting factor was off. And there was no way we could have anticipated that, but that ended up being the truth. So I urge everybody to be somewhat humble and compassionate when we come to the idea of voice care and when we are counseling our students on these things that I'm going to be talking about today. So all of this information can serve as a great reference and a point of discussion and a problem-solving tool, but I want to caution people against weaponizing it against their students. All right, so now we get into hydration. Let's talk about hydration. The important thing about hydration is that the vocal fold, and I have this small picture over here of the vocal fold where you can see it sort of sliced from the side, and there's the muscle deep inside here. And then we have this gray area that represents the lamina propria. The lamina propria is sort of the cover of the vocal fold, if you will. And they've got it stained in two different colors. The darker area in the middle is the intermediate and deep layers of the lamina propria, which is referred to as the vocal ligament. And then this lighter area is called the superficial lamina propria, and it's all covered by a thin layer of epithelium, skin, essentially. So the way that the vocal fold vibrates is that this superficial lamina propria has to be very fluid and jelly-like. And there needs to be a sheen of thin mucus across the top of the skin of the vocal fold to prevent friction from building up. So this is some of the reasons why hydration is actually really important for voice. And in fact, we do know that when someone is well hydrated, what they call phonation threshold pressure, or the amount of pressure it takes to get the vocal folds to vibrate, goes down, which is good. We want that. And we know that the vocal folds can be hydrated both internally and externally. I love this, this phrase, transepithelial water fluxes, meaning essentially that the fluids can kind of go back and forth across that membrane, and what's inside can impact what's outside, and what's outside can impact what's inside. So the thing is, though, some people go a little nuts in terms of water. So I think that, first of all, we want to put it into context to say that the old yarn about 8-ounce glasses of water per day was actually kind of random. Someone just came up with it. And then on the far side of that, sometimes people tell me, oh, I'm trying to drink a gallon of water a day. And I really have to put the brakes on that and say, whoa, you might be trying a little too hard, because you can drink enough water to set off your electrolyte balance. And then that can actually be a really negative thing. So the best advice we have right now is the phrase pee pale, which essentially means that when you urinate, if the urine is a very light color, then you're well hydrated enough. So very, very light yellow, maybe almost clear. You know, it's like going to the paint shop where you get those little samples. Is this kind of almost white, or is this not? It's kind of like that. The darker your urine is, the less hydrated you are. So if you urinate and you have very dark yellow urine, unless you're taking some kind of medication or a vitamin that changes the color of your urine, like vitamin C and vitamin B can sometimes temporarily change the color of your urine, then you know you're not well hydrated enough. So that's a good guideline. Also, it's important to remember that there are a lot of things that count toward hydration. So certainly water, we love water. Herbal teas will count, juices count, milk counts. Low sodium soups and things like that count. Coconut water is super popular, that counts. Even, and this came from a nephrologist who studies kidneys and hydration function in the body, and they said that even coffee, someone who drinks 1 cup of coffee per day and does that consistently, the body adapts and it no longer has a dehydration effect, which I thought was really interesting, because caffeine can be a diuretic. But then she mentioned that there is a threshold that if you drink a certain amount of caffeine, then it starts to trigger that diuretic effect. I have a piece of watermelon here because I had one patient who was hardly drank any water, but on discussion, she actually ate an entire watermelon a day. And only person I've ever had that did that, but she, it turned out, was actually well enough hydrated from her one huge watermelon a day. Okay. Reflux is another interesting thing to talk about. It is at the same time both over and underappreciated by different people, depending on who you're talking to. What we hear about in the advertisements is GERD, gastroesophageal reflux disease. We don't really hear about the other one, LPR, laryngopharyngeal reflux, because there's a low incidence of heartburn. So GERD, people will talk about, you'll see the advertisements, it'll be all about, oh gosh, I'm feeling this reflux, I'm getting heartburn. And that is because you'll see the picture here that we have the same mechanism, either this, what we call the lower esophageal sphincter, the bottom of the esophagus is either tightly closed to keep things in the stomach, or it's slightly open or loose that allows things to come up. Now, the bottom of the esophagus here is made of a tissue that is actually somewhat tolerant of a certain normal amount of reflux. So it doesn't actually throw off the signal of heartburn until it's past that threshold. Now, when you get a lot of reflux that's hanging down in the lower esophagus, you will certainly get reflux. Will certainly get heartburn. What happens though with laryngopharyngeal reflux is much smaller amounts end up coming up all the way to the top. And the esophagus and the larynx are neighbors, with the esophagus in the back and the larynx and the airway in the front. So anything that comes up to the top can kind of drizzle around in that area and cause some swelling and some irritation that then becomes problematic for the throat. So the LPR is sometimes called silent reflux because those small amounts pass through the esophagus. The esophagus doesn't care because it's a small amount, so it doesn't throw off the symptom of heartburn, but instead people are feeling lump in throat, persistent feeling of the need to clear their throat, like there's something in their throat even when there's not. Sometimes vocal fatigue or voice changes can come with that as well. And so that's the difference between the two. But often I have to explain that difference in symptoms because people are so used to thinking if they don't have heartburn, then they don't have reflux. But if you have these other chronic throat symptoms, you might. So I think that's the important conversation to have. And when I'm talking to patients and I'm saying, well, here are the symptoms of throat reflux, and they start to go, oh, wait, I have that, right? And this is something doctors, I think, they just don't have the time or even honestly sometimes the knowledge, except for laryngologists, to explain. So we're going to talk a bit about medications. The important thing to know about them is that most of them do not solve the mechanical issue. They lower the acidity of the reflux contents, but they don't actually stop reflux. And this is really important when it comes to talking about how you can control it. There are a few things that put us at increased risk. Hiatal hernia, increased age, stress, and a family history can put you at increased risk of reflux. So what are some things we can do? So first of all, there are some issues having to do with food. There are certain foods that we know loosen that lower esophageal sphincter. All the fun stuff: caffeine, alcohol, chocolate, fatty, greasy, creamy, fried foods, mint and onion can loosen that lower esophageal sphincter. Then there's another set of foods that in and of themselves can be somewhat irritating because they're acidic or can bring up burps. So for example, tomato products and sauces, citrus foods, anything that's very tart and carbonation can cause some burping and bring some things up with it. So those are things that they might not impact the status of that lower esophageal sphincter, but they can increase your signs of reflux simply because they can be in and of themselves somewhat irritating. And I find it's really, again, I like making these little distinctions because it's really overwhelming to talk to somebody about reflux and say, here's a big thing of things that can cause problems. And people shut off. So I like to say, well, there's a few that do this. And there's a few that do that. And now let's talk about what's in your diet and what you feel. Another issue with food can be food sensitivities and allergies. And so, you know, that's something that you might have to talk to them about, work with, figure out if they're looking at that with their doctor. Other things though that you can talk to somebody about, you can say, listen, also, are you overfilling your stomach? Are you taking a giant meal and then, you know, trying to do something? Your stomach can't digest any faster than it already is. And so the only way to relieve the pressure is back up. Also leaving time to digest after eating, whether that is exercise or heavy activity, leaving time to digest before laying down. And maybe sleeping on an incline. So I have this picture here of a wedge pillow that can be very helpful. Notice the wedge pillow does not only elevate the head and neck, it's elevating this entire area because remember, the problem starts at the junction of the stomach and the esophagus. And so if you're going to use this to help work with gravity a little bit, then your entire torso does need to be on that incline. And then things like avoiding tight waistbands. Now, these can be challenging to talk about in the performer's world, because what happens, you know, I'm going to be performing a show. I don't want to be eating a big dinner necessarily before the show. So I might, an hour before the show, have something to eat. But then, you know, again, I was in the rock world, so it's like 1 o'clock in the morning, and we're loading out speakers, and I'm trying to eat something, and as soon as I get home I want to go to bed, you know. So there are some things, some problem solving you have to do. Tight waistbands, you know, you have some people who have costumes who have issues, so it's again a holistic issue that you're trying to help them deal with and figure out how to make the most of reflux control. This is just a basic primer on the medications. The ones that we're most familiar with probably are the proton pump inhibitors, and they work by reducing acid in your stomach, and they sort of turn off these things called the proton pumps, and that's how they reduce the acid. They're most effective when taken 30 to 45 minutes before eating, and a lot of people forget that piece. Once you've activated the proton pumps, there's nothing left for the medication to bind to, so you're kind of too late. They're also generally meant to be taken not only when you don't have symptoms, when you have symptoms, but for like if you're having a reflux issue for a while, you might take them for a few weeks, or in the case of a problem with someone who's really got throat issues from laryngopharyngeal reflux, then you might actually take it for a number of months. And people who have chronic reflux issues might be on them long term. Important to mention, Zantac, also known as ranitidine, which was something that we used a lot to help people with reflux, has been removed from the market. There is, and even as of April 1st, I checked in with it again, the FDA requested withdrawal of all forms of ranitidine because there is something about the way the body is processing it that turns it into a carcinogen. There are other medications in the same class of medication that do not seem to have the same problem. And so those are below that here. That's the Pepcid, Tagamet, Axid. So anything that ends in dine, tidine, is in that class of medication. But the ranitidine, if you have that in your cabinet, you probably want to dispose of that and perhaps try one of these others. And your doctor will probably know more about that as well. Things like Tums, Alka-Seltzer, and Mylanta, they just neutralize acid once it's present. So they're very symptomatic control. Now the new kids on the block are the alginates, and in particular, not so much Gaviscon US style, but Gaviscon Advanced from the UK, and then also Reflux Gourmet, which was created by a laryngologist and a chef here in the Boston area, actually. They use a thing called alginate that when you ingest it and it combines with the stomach acid, it creates this foamy barrier that then floats up to the top of the stomach where it joins with the esophagus. The cool thing about this is that this is actually then the one type of medication that actually stops the reflux, because it creates a barrier between the stomach and the esophagus. In order to use it most effectively, you want to make sure that you're not continuing to eat and drink after you've taken it, and then the effect will last for a few hours before the body just kind of digests it away. But it can be handy if, say, you have to do something strenuous soon after eating, and it can be handy for the nighttime refluxers as well. Okay, so moving on to allergies. So allergies are an immune response, and it's different from an intolerance. And I think that that is particularly relevant to food discussions, where sometimes people think that if a food gives them indigestion or causes them some other problems, they have an allergy. They might actually have an intolerance instead. So an allergic response is an immune system response. And so you have immune system chemicals going through the body. It creates inflammation, mucus production, fatigue. Often in terms of, in terms of food, we're talking about you eat something and you get anaphylactic shock or a closing of your airway versus like lactose intolerance where you just lack an enzyme and then you have some gastric distress and perhaps flatulence and other things like that. So that's the difference. Two basic ways to control it. There's avoidance and environmental control, and then there's medications and injections and those kinds of things. So I think that environmental control is really important. And in fact, when I was first diagnosed with allergies myself, my allergist made a big deal about helping me to understand the importance of my bedroom as a place to keep allergen free, because when we're sleeping, our body kind of clears away a lot of these responses. It kind of brings things back to baseline. And if your sleeping environment is full of allergens, then what happens is your body never really gets a chance to empty the bucket of all the allergens, and you end up in a situation where you're constantly still having this allergic response. For those who are allergic to dust, I cannot say enough about dust mite covers for your bed. It makes a huge difference. You don't think about it that the dust actually and dust mites make their way into the mattress and the pillows, and then as you sleep and you move around, puffs of dust are coming around you as you sleep. And so there are these special dust mite covers that you put on the pillows, the mattress. Some people also put them on comforters and the box spring as well, to make sure that that all gets contained. And then every time you strip off the sheets and clean them and things like that, then you know you're actually kind of taking the dust with you and it's not getting into the mattress. Makes a huge difference for people. I also want to talk a little bit about medications for allergies. I think sometimes singers get a little paranoid about allergy medications because they are drying. So a couple of things about that. First of all, medications really vary in terms of how drying they are, and people can have individual responses to the drying. So some people may take one medication that makes them feel very dry and then switch to another that doesn't. And this may vary from individual to individual. But you also have to consider what are the consequences of allowing your allergies to continue. And this is the place where I see that singers sometimes don't see the big picture. Let's say you had high blood pressure. So if you have high blood pressure, you're probably going to be put on a medication that is overtly a diuretic, something that's going to take water out of your system. And yet we kind of understand that it's worse to leave your blood pressure untreated, because you can have a stroke, you can have all kinds of other things if your blood pressure is untreated. And so we say, oh, well, I have to take the medication. From the perspective of allergies, if you're getting postnasal drip and throat irritation and swelling in your larynx, and then your voice is off and you're coughing and you're sneezing, all of those things are going to have some kind of consequence for the voice and how your voice is functioning. And so if you're able to find some kind of an allergy medication that controls that, and you can drink a little extra water to overcome whatever drying effect you're feeling, you're probably going to end up much better in the end than just saying, oh, I need to avoid all allergy medications because they're drying. So it might take some experimentation to find what's the right combination for you, but don't write off things like allergy medications simply because they're a little drying. In terms of food allergies, I think that here I talk about the ABA single subject design. Basically, you say if you think it's impacting your voice, then take a log of your symptoms that you think are associated with it for about a week, and then don't have that food for a week or two and log the presence or absence of symptoms. Bring the food back and see if they return, and then remove it again. That's actually a a scientific way to do single subject designs, and will give you a much better sense of if it's truly causative than your casual observation of, oh, I think this causes me problems. And finally, get tested. I can't tell you how many people are like, yeah, I have allergies. Have you ever been tested? No. So they don't really know what they're allergic to. They can guess based on time of year, maybe. But if you know what you're allergic to, you can much better take specific action to make yourself feel better. So, so get tested. Even if you're like, yeah, I know I have allergies. Find out allergies to what. Okay. Airborne irritants are, I think, an interesting conversation to have. So first of all, it is not just cigarettes anymore. It's vaping, and with the increase in legalization of marijuana, there are more people that are ingesting marijuana, and a lot of those people are choosing to smoke it. And so we have to maybe just find out what people's habits are. And interestingly, I find you have to break it down, because if you say, do you smoke? People in their mind think cigarettes, and they'll be like, no. And then you find out they're vaping, and you say, well, that's still an airborne irritant. And I've really pivoted towards using the term airborne irritant so that I can talk about everything. Anything you're breathing in, because it's not even just things like smoking and vaping and marijuana, but maybe pollutants. Or one of my patients was having these bad reactions to her mom loved to have like these Glade plugins around the house. It's an airborne irritant. Anything we can smell has particles that we're breathing in through our airway. It was very irritating for her. So by having this more broad category, I think it allows people to feel more comfortable talking to you about what they're doing, and you can have a back and forth conversation about it. Inhalers are, obviously a delicate conversation, because breathing comes first regardless. We can't sing if we're not alive. But we do know that Advair in particular has a much higher percentage of people who seem to have voice problems when taking it. Now, the voice problems seem to go away after about 3 or 4 weeks or so of discontinuing it. But you really have to tell your patient to work with their doctor, because often their doctor can just say, okay, let's try a different medication for you. And because even I have had the problem of saying, okay, talk to your doctor about this. And then what does the patient do when they get home? They just stop their Advair. And I'm like, no, what I said was talk to your doctor about this, because we have to problem solve it. And then like, yeah, I'm not breathing as well. I'm like, well, yeah, because you have asthma, right? So, so especially as a teacher in that world, it's like, yeah, so we know that some inhalers can cause a problem, but breathing is still primary importance for you as a living human being. And, if there's an issue, maybe you at that point you'd be sending them to a medical team, and we'd be the ones to inform them that, hey, let's see what we can do with something else. So at the bottom here, I talk about just how I approach things. It is much better to have a conversation of, gee, what can we do to sort of control or reduce your airborne irritants, than it is to say, you should stop smoking, you should stop vaping. And, as an aside, I will say that, yes, I will teach people who are smoking or vaping. Like, again, I am not going to be, I have no right to be judge and jury, honestly, about what people are getting out of their voice. Airborne irritants can cause some short-term issues, but really they're a long-term issue. And we know for a fact that people have had long careers as smokers and then eventually suffer some kind of consequence. But I don't feel like personally, and it's a personal decision, for every teacher to make. I still run into teachers who will say, I will just absolutely categorically stop teaching someone who's smoking because they're ruining their voice. And just my perspective again is I can help them get the most out of their voice for as long as they can, and the long-term consequences are theirs to bear. And it is not on me to judge. So that's kind of that's where I come from on that count. I know a lot of people feel differently about that. So general voice care here, general body care is also important to consider. We know that everything that happens to our body also impacts the voice. And so, you know, if there's an issue with sleep, if they never exercise and then they seem to have like low postural control or low low control of their respiratory system and such like that, it might just inform you as to where some of the issues are coming from. But also, I think a lot of times people don't talk about the controlling chronic medical conditions as well. So if somebody has an uncontrolled medical condition, a lot of different conditions cause an inflammation effect in the body. And so that's going to affect the whole body, not necessarily only one part. And so, some of the funky light voice issues can sometimes be tied in with that. Okay, so stress and the voice. None of us have a problem with that, I'm sure. Our stress mechanism is also called the fight, flight, or freeze response. And it's one of the oldest areas of the brain. And so in the little brain picture here, I'm kind of showing you the deep centers of the brain here. And there's a number of different areas that are responsible for our fight or flight response. But we can kind of think of this on a little seesaw. We have fight or flight response comes up, or the opposite is what we might call the rest and digest response. And the fight or flight system is called the sympathetic nervous system response, and the rest and digest is called a parasympathetic response. And these two are constantly teetering back and forth. When the stress system is activated, there's a whole physiologic response that includes changes in circulation, heart rate, respiratory rate, muscular sort of standing tension, even when you're not doing with them any. If the fight or flight system is engaged, they're going to be slightly tense, ready to go, ready to do something. This system was designed for short-term activation followed by deactivation. And so what I mean by that is that what this system does best is if you see something like, okay, there's a bear, this system is going to light up and you're either going to fight the bear or run away from the bear. And then the system will deactivate one way or another. Either you're going to get eaten by the bear and then it deactivates, or you're going to successfully escape from the bear and then you're safe. So our problem as modern humans is that we have this constant low level state of sympathetic activation. We have things that we have labeled that stress us out. So it could be deadlines, it could be presentations or performances, it could be bad social situations, a bad work situation, and we're just always a little bit here. And this is going to affect the whole body, including the voice. And there is a direct connection between the limbic system neurologically and this whole area of our body. And so I think that a lot of people already instinctively understand this, in that sometimes at the beginning of the lesson, we do some movement, we do some breathing, sometimes some centering or mindfulness activity, and then we kind of come into it. A lot of the people that I see in clinic actually are dealing with this as part of the problem. They've been diagnosed with this muscle tension dysphonia, which it's not that that's not true, but it's not the whole story. What's driving the muscle tension dysphonia is this chronic upregulated limbic system that's keeping them in a state of mild muscle contraction body wide. And sometimes we need to address that. I will say that absolutely. So I was assigned, unfortunately, to a group of people that had to go around the emergency room and the floors during the COVID crisis, actually giving people COVID tests. And sometimes arriving around the same time as the portable x-ray machine and being able to see, okay, yep, that test I just did is going to be positive. I was in probably the longest state of sustained fight or flight that I've ever been in. And I could see myself hyperfunctioning vocally. I could feel myself hyperfunctioning. My speaking resonance was thin. I had tense. And even with all my strategies in that extreme state of fight or flight, I couldn't fix it. I couldn't stop it until I was out of that situation. So you might think of some of your students who are dealing with intense health issues for themselves or their others, systems where they're maybe experiencing abuse or things like that, where maybe the fight or flight system is part of what you're dealing with if you're having trouble with them progressing vocally. So let's talk about use factors. I avoid the terms misuse and abuse. And this started way back when Catherine Bertolini was talking about this when I was in grad school, and I was like, oh, that totally makes sense. So she converted me immediately. The term I use is phonotrauma. It is a much more neutral term, and we can talk about phonotrauma without being judgmental about what a person is doing. So what are some common phonotraumatic activities? Well, yelling and screaming with abandon can be phonotraumatic. Chronic strain, coughing and throat clearing, speaking or singing for long periods of time, and especially in poor environmental conditions, can also be phonotraumatic. And yet, if somebody has an upper respiratory infection, you can't tell them not to cough. They need to. If somebody for work is working at a warehouse, they might need to use their voice loudly. I had one patient who was a fireman, and he had to use his voice while wearing equipment and then over some kind of speaker that they had available to them. So people need to do these things. And so so by labeling them abuse and misuse, we sort of end the conversation there. If we turn to the idea of phonotrauma, then we can have a conversation of, okay, these things could be causing problems for you. How can we mitigate the risk? Can we train you to use your voice more efficiently and have more vocal skills? Can you take voice breaks? Can you, what can we do? And it opens up a wide variety then of problem solving where you can work with the person to say, how can we decrease the level of phonotrauma? But, there can be some roadblocks to change. And once again, I guess my theme always really is trying not to be judgmental. If somebody isn't making a change immediately in some kind of behavior, even if they say they want to make the change, there may be a number of reasons why they aren't. Habitual behavior is very difficult to self-monitor, whether it's vocal behaviors or things that they are doing outside in the community. If it's a habitual response, it is actually really difficult for people to develop the ability to see it and then intervene in time. And some people, as we all know as teachers, there's just variations in kinesthetic awareness. And so some people can very easily tune into the feel of something, and other people just don't feel it. And that can be really challenging when we're talking about changing vocal behaviors that you can't see. In a sense, you kind of have to feel or hear them. Then there are personality factors, and there's just some interesting studies that Nelson Roy and his team have done regarding looking at different personality factors as they define them and what kinds of voice disorders they get. I think the first paper of his that I read had to do with what people get what's called functional aphonia, where the system seizes up and they're not making sound at all, even though their system is normal, and people versus people who tend to get nodules. And they kind of had a little theory on what some of the differences are. So again, we're kind of dealing with whole people here. But also people have ambiguity about making change. Ambiguity, that's totally the wrong word. Ambivalence. So when you get your hand out, you can cross that out. It's ambivalence about change. That even if they see that they kind of want to make that change, there's often some kind of cost that goes along with that. You know, it may be, I want to stop my reflux, but I really love my coffee. That's a super common one. But it also could be, I want to engage in less phonotraumatic behaviors, but the way my group of friends socializes is going out to the bar every Friday and Saturday night. And now there's a cost. If I don't do that anymore, I don't get to see my friends. So there can be a lot of ambivalence. And I'm personally trained in something called motivational interviewing, which is not actually something that's only open to people, I think, who are medical professionals. So if you find the opportunity ever to get a little bit of training in that, it really helps you guide these conversations to help the person you're talking to understand their own motivations for changing and not changing. And so it can be a nice tool to have in your bag. So, but you know, some of the basic factors are that you know, you can ask open-ended questions about their experiences or situations having to do with something that they might benefit from changing, and then from their answers you kind of reflect what they've said back to you and ask them for ideas on what could be a solution to that problem. And you'd be surprised when you're guiding instead of telling. Oftentimes people come up with their own ideas that they can live with and really make an impact on their problem. Now here we are with vocal load. This is fascinating. It's a new paper out by Eric Hunter and colleagues having to do with vocal fatigue. There was a series of videos that you can Google it and look it up. I think it's still up there, that the Voice Foundation did this year, a whole series of 5 videos having to do with the theme of vocal fatigue. And in one of those, Dr. Hunter was talking about this new research. I love it because it breaks it down into these 4 different areas: vocal demand response, vocal effort, and vocal fatigue. And what's really important to understand is that vocal demand is independent of the individual who's going to be speaking. It's what's the requirements of the environment that they're in. Whereas vocal demand response is how does that individual physically try to meet the vocal demand. Vocal effort then has to do with the speaker's perception of how much energy that they're using to meet the demand. And vocal fatigue would be something measurable in terms of a decline in function. So I just love, and you can watch one of the video of Dr. Hunter talking about this, and the paper I think is out there to be had and read as well. I think that it's really helps to then figure out, again, what's our point of intervention here to minimize vocal fatigue. And of course, we all know this. I put this up here just to remind people that vocal load, you know, oftentimes people don't think about all of the things that they're doing. In teens, there's this huge issue with, well, they're in general choir, and in order to participate in select choir, they have to participate in general choir, but then these are the same kids who are interested in drama and the musical, and oh, twice a year there's a coffee house, and that's a lot of fun, and I'm taking my lessons. But there's this cool outside of school musical theater program that I'm doing on the weekend, and on Friday nights I jam with my friends, and it's all really fun, and they're doing it all. And they don't, you know, consider that their mechanism may or may not be able to handle all of that in addition to all their normal talking and socializing that they're doing. Similarly, gigging professional, we know, right? Rehearsals, performances, interviews, recording new material, selling merch, that's a huge one because a lot of the record sales income has gone away. So they're having to sell merch to make sure that they make up some of that income. And everybody wants to talk to the singer, even though I tell my professionals, I say, send the guitarist to the merch table. Anyway, networking, negotiating, talking to fans, day job, teaching, all at the same time. And you can really get into the weeds with somebody when they start saying, yeah, but my friend or my colleague can do all these things and not have a problem. Why do I have a problem? And I just have to shrug and say, I don't know. Because there's this variability in terms of how much vocal load different people can handle. And there are going to be some people who can do great with this amount of vocal load, but then the minute you gave them this amount of vocal load, they just can't do it, even under the best of circumstances with the best of training. Everybody has an individual limitation. You don't necessarily know what that is until they're well enough trained and coordinated enough to know. But wherever they are in their training, that vocal load needs to be adjusted if possible. It's a really difficult conversation to have and to try and problem solve, but and I think we've all been there. So let's start talking about medical care for the voice. When do I suggest people come in? Sudden change in the voice when not sick. Especially in the context of a phonotraumatic event. So one of my voice therapy colleagues got mugged, screamed, got a vocal fold hemorrhage, right? Just knew by the time she got to work on Monday that things still weren't right, scoped her, yep. But it was fine in the end, but that early diagnosis helped make sure that that she was able to take measures, which in this case were voice rest, to get better quickly. Sustained dysphonia, which means trouble with the voice after an upper respiratory infection. Now, upper respiratory infections can linger a little while, especially from the singer's perspective. The point at which an average person is like, oh yeah, I'm all better, is going to be different for a singer. We might notice for weeks. But if you're getting 2 weeks out, all the rest of your symptoms have resolved, and you just don't feel like your voice is continuing to improve, like if you feel stuck, you might want to just go in and make sure that nothing untoward has happened. Pain, there shouldn't be pain when speaking or singing, and so chronic pain with speaking or singing, or even just chronic pain when you're not speaking or singing, is something that should be at least investigated. Throat or neck trauma, so people who have had blunt force trauma to the neck, people who have had attempted strangulations, things like that, should just be seen, even if they think everything's okay for the time being, just to get checked out. And then I added Spidey sense at the end because as a singing teacher, you get a sense over time for what makes sense. And even if you can't put your finger on it, you're like, this doesn't make sense, it's not quite right, send them in. You know, there is no harm in having them come in and be evaluated. And I have had far more times when somebody's been sent in by their teacher and where something is actually going on than times when something hasn't. And so do trust your instinct, even though you might not have the scientific training. You see a lot of singers all the time, and you get a sense for what is typical and what's not typical. So do trust that instinct. So in terms of medical care for the voice, I like to make the distinction between the general practice ENT and a laryngologist. This is really important, a very important distinction. A general practice ENT does everything to do with ear, nose, and throat. And all of my laryngologist friends have told me that in general ENT training, you get a lot of E and a lot of N and just not a lot of T. So anybody who wants to work with voice on a regular basis is going to do additional specialized training, perhaps a fellowship and other things having to do specifically with diagnosis and treatment for voice. And so they're called then a laryngologist. Now, on different hospital web pages, they might not make the distinction as clear as I'd like them to make sometimes, but you can usually tell by looking at somebody's clinical interests, where they've had fellowships and things like that, if they're truly a voice-focused doctor. And I cannot stress the importance enough for singers who are having a problem to see a laryngologist. And I absolutely recognize that I'm here in Boston. There are a number of voice centers here with good laryngologists, but some people in rural areas or less populated states, their student might need to travel to the nearest major city to find a voice center, and that can be an incredible investment of time and effort to do so. But I do feel strongly for it for singers, and I really try to make sure people advocate for that, because only a laryngologist is going to be able to look at somebody in a detailed enough way that's going to get at some of the problems singers experience versus sort of a typical voice user. A similar divide, though, is present between general practice speech pathologists and voice specialized speech pathologists. The realm of speech pathology scope of practice is enormous. It runs everything from school clinicians treating kids with autism and stuttering and, language writing disorders, all these kinds of things, to swallowing disorders, acquired traumatic brain injury in adults, strokes, and voice. Right? So we get this generalized training in our grad program, and that is going to include one class usually in voice disorders. So just like with the doctors, if you want somebody who really has a toolbox of voice tools, you need to seek out somebody who has done the additional work, continuing education, mentoring, observing, really trying to flesh out those skills to become a voice specialized speech pathologist. Because otherwise, like, this is an extreme example, but at one of the clinics I worked at, we ended up getting a patient from a speech pathologist who'd been having voice therapy for 74 sessions. A typical voice disorder should be treated in maybe 8 to 10 sessions. And if that was going on that long, it means something's not going right, either on the diagnostic side or the treatment side. So, okay. The process, we have the laryngology assessment, the speech pathology assessment, and laryngo video stroboscopy, and then an acoustic and aerodynamic assessment. I think what I'm going to spend my time on now is the laryngo video stroboscopy, because having a stroboscopic examination of the voice is extremely important. What that means is that someone sticks a scope either in your mouth or in your nose. On the left here is the mouth scope, and in the middle here is the nasal endoscope. And there's a light that shines through there, and it's a strobe light. You put a microphone to the side of your neck and make sound. The microphone sends frequency signals to the computer. The computer makes the strobe light flash just barely slower than the frequency of the vibration of the vocal fold, which puts them into apparent slow motion. And now we can see kind of what the wave looks like as it goes across the top of the vocal fold. We can see how well the vocal folds are shutting in the middle, how flexible it is. And when they go high in pitch, you can see if that stays the same. You can see subtle changes in the edges of the vocal fold. And these are not things that you can see in just an exam, even with the same instruments that are connected to just a steady state light source. And the function of the voice has to do with that vibration. It has to do with the mucosal wave and the glottal contact and all of these things that you just can't tell from a steady state light. So I have a video here. Now, one thing that I noticed, the controllers for the video come up over the pause button for me. So I'm just going to play the video straight through, and I'll just tell you what the segments are in advance here. One is normal, just some brief pictures of vibrations of the vocal folds so you can see what it looks like to have it vibrate. The next one is somebody who has an upper respiratory infection, a cough, and one of the differences that you'll see is there's like just some extra mucus hanging around, and the vocal folds, instead of being completely even in vibration like this, one's like kind of vibrating a little bit more out than the other, a little bit kind of like this. And then there are two samples of vocal fold paralysis. In one of them, the person has a better diagnosis than the other. The first one, you'll see that even though it's kind of squeezing, the vocal folds are making decent contact. In the next one, you'll see that they actually have a concomitant swallowing disorder as well. And so there's lots of mucus and things like that, and the vocal folds are making poor contact. So I am going to start this playing. So here come our normal vocal folds. Still pearly white in appearance. Oh yeah, I successfully paused it. Okay, so I want to orient you too. This is the front down here towards the bottom. The back is towards the top. These towers here are the arytenoid cartilages, which are like, they're like pyramid-shaped hinges that open and close the vocal folds. The vocal folds themselves here are these white bands. So she's high in pitch right now, and so the vocal folds got a little bit longer. Over out to the side here are the false vocal folds. When they start to squeeze together, it can be a sign of stress and tension. Way in the back here is the back of the throat. And then the esophagus opening is actually right here in this little fold of tissue. It's always closed unless you're actually swallowing. So now that maybe I can actually get in there, let's see if I can make it go again.
Still getting shots of that. Can you do that again?
So this next one, again, somebody during a cough, when they have a cough, and so things are a little bit more irritated. The color isn't quite as good of the exam in general. Something must have been off with the white balance during this video. Oop. Oh. I knew that was going to happen. See, there's a little bit of mucus there. The chunk of mucus now hanging onto the vocal folds. And the edge it's still vibrating okay. It's just not quite as organized, perhaps, as the other one. Now, oh, that's right. I forgot about this one here. So this is a voice injury. And so this person has a resolving hemorrhage as well as bilateral vocal fold lesions from a phonotraumatic injury.
And then E.
You can see a lot of redness. Right. So you can see the uneven vocal fold edge. You can see blood vessels. You can see resolving redness here. There's extra mucus around the side. This person did eventually go back to singing afterwards, a slightly different type of music than she sang previously. Oh. Okay, so this is note to self for the future. Okay. All right, now this is, once this side of the vocal fold is not moving, but this other side is moving, you'll see that she's working really hard. Both vocal folds are coming together, but she's making decent contact.
Aclarar. Aclarar. Hilado.
This next person here,
For me.
there's
Shut
a
mouth,
lot
great.
of
And then only
mucus
sniff,
around
sniff.
here
Only sniff,
because
sniff. Only sniff, sniff.
they have a
Only
swallowing
sniff, sniff.
disorder as
Only
well.
sniff, sniff. Only sniff, sniff.
This vocal
Only
fold
sniff,
is
sniff.
not
Only sniff,
moving.
sniff.
This one
You're
is.
doing great. Only sniff, sniff.
And what you're going to see
Great.
is
Now I'm gonna have
that
you go
these
eat,
false
eat,
vocal folds
eat,
actually come together
eat.
and
Great.
vibrate.
Lots of those. Yeah, just long. You don't have to work hard. You just have to do it long. And
vibrating.
eat. Do that again. Eat.
Because underneath the true vocal folds are not
And
getting
again.
great contact. So those are just a few different things to look at in terms of what we see. We see a lot of different kinds of things, but I thought those might be a few interesting types of cases for you to get a sense of what we're looking at when we examine people.
Excuse me, Barbara.
Yeah.
Hi. We have a lot of questions, so I was wondering how long you're going to leave for the question and answer.
I have just probably about 5 more minutes.
Okay.
All right.
Thanks.
5 or 6 maybe. Maintaining communication between you and the team is important, but they're going to need to sign a form for us to be able to talk to you. Otherwise, we have to deny that they exist. Important to tell them to sign the HIPAA form that lets us talk to you if you want to communicate with us. Ethics, you can lead a horse to water. What if they don't make the appointment? Again, kind of open to individual interpretation. I am obviously more comfortable sticking with somebody a little longer, but there may be a point at which you wouldn't feel comfortable teaching them anymore, and that's going to be individual to you. What's the deal with straws? So people are really excited about straws. It's in a class of exercises called semi-occluded vocal tract exercises, which means partially blocked at the front. So what happens is when you partially block something in the front, you build up back pressure. So you have pressure from the lungs coming up. Now you have pressure from above. And so that actually decreases the collision force between the vocal folds as they vibrate, changes the shape of the vocal folds as they vibrate. That's the fundamental principle. Straws are great, but they're not magic. There are tons of ways you can get semi-occlusion. Z sounds, M sounds, lip trills, straw in water. So lots of ways to do that. It's really more a principle than an exercise. So, when you get into sort of understanding what semi-occlusion does, then you can have more confidence moving around. Okay. Quick thing into COVID-19. Obviously, we have impacts on the respiratory system and the phonatory system and general body condition. This picture up top is showing you what intubation is. That is where they have to send an airway tube down through your mouth, through the larynx. And this is a picture of a cuff that is maintaining the airway so that somebody can continue breathing. And the ventilator is the machine that sends air into the lungs. It does that under pressure. And so it's pressing air into the lungs. And the important thing to know about that is actually the pressure from the ventilator and the COVID-19 itself can actually cause lung damage. There is a difference between planned versus traumatic intubation. And so, my observation was that usually people who were needing to be intubated for COVID, they weren't thrashing around, they didn't have neck injuries. So it was, generally as gentle an intubation as you could possibly get. But the thing is, it's usually short term. And with COVID patients, we were having people intubated for a month or more. So the longer the tube is running between the vocal folds, the greater the chance there is of abject damage to the vocal folds and the larynx itself. In addition, they discovered that with COVID patients, if they proned them, turned them face down, and alternated between up and proning, that they did better in terms of their oxygenation. Well, now you've got a tube down your throat and you're being turned, and this tube gets turned. And so we are seeing some laryngeal injuries from this. So there's a lot of talk about how do we return to lessons. I think that depends on your environment, but I think, you know, for most of us, virtual lessons are gonna stay safest for a while. That's kind of my overview of that. And then as a last thing, I just wanna let you know, there are a couple of things that I want to offer to anybody who's here. I have a chronic cough course that's up, and I put together a discount code for anybody who wanted to take advantage of that. And then with another teacher, I'm working on a Singing Through Puberty e-course, and I want to offer anybody who is here at the LoVetri the chance to get also a discount on that when it's ready. So I will send that information to Billy and Jeannie when it's ready, and you guys could take advantage of that if you wanted to. And that's where we are. So I am happy to take questions and answer whatever I'm able to.
Okay, well.
Let me unshare. Let me stop the share, I guess.
I think that you could speak on some of these topics for another whole hour. So I put them together in the on topic, together with the topic. So someone says, can you speak to using guaifenesin, Robitussin, as an additional tool to use for hydration on the mucus fold level?
Oh, okay, yeah. So what guaifenesin is it is a mucolytic. What that means is it takes mucus and thins it out a little bit. So it's not, sometimes it makes people feel better hydrated, but it's really what it's doing, it's thinning the mucus that's there. And so if you're a person who has trouble with thick mucus, then some people do find that helpful. There's just one little caution, I guess. Some people can have a negative blood pressure reaction to guaifenesin. It's pretty safe for most people, but if you're going to use guaifenesin, you'd be looking to use something that only has that and not anything extra. And then just if you have anything going on with your blood pressure, check that out with your doctor. So it's thinning the mucus to make it less in the way.
A lot of questions on reflux, as you might expect. I was told once by a laryngologist that reflux is chronic singer's issue because of the constant abdominal pressure on the stomach. Is that possible in your opinion? And or are we more sensitive to it because of our hyper focus on the voice?
I think a lot of times it depends on what you're doing and where in the digestive cycle you are. So again, I think it also comes down to one reason why singers don't like to eat too close to a performance. You are a lot less likely to reflux if you don't have your stomach full of food. And when you include the fight or flight reaction, such as we get with performance anxiety, and when we're feeling nervous before a show is actually a low level fight or flight, then your digestion goes down and the food stays in your stomach. So I think that it all comes together and plays together. And also there are some kinds of singing that use more pressure and some that use less pressure in terms of that junction between the abdomen and the diaphragm. So I would say it depends. But then absolutely, I think we as singers are we're going to notice small things more than anybody else. And so we have and our voice function, we have less tolerance for issues. something that wouldn't be a problem for somebody else is going to be a functional problem for us. And so then that's why we have to sort of maybe make some lifestyle choices that other people don't have to make in order to control it at a higher level.
Okay, I'm going to try to combine a bunch of questions. So it's about how long are PPIs effective and about their negative effect on the voice, also on their negative effect of the absorption of minerals like calcium and magnesium, and how do you wean off them carefully?
Okay. So,
sorry.
Yeah, there have been, no, I think that's a great summary. I'll bet there were like 30 questions that boiled down into. So we do know that now that, yes, there are some issues with minerals and things like that. There have been other sort of things popping up in regard to proton pump inhibitors that are less certain. Like many things in the media, the minute a paper comes out, the media wants to say, hey, this is this. And really it's like, well, one study said this and one study said this. But I think the things with, I'm pretty sure it's vitamin K and something else is pretty well established. So, the first thing to think about is the cost benefit for any particular medication. And so the thing is, if you are a person with chronic ongoing reflux, and if behavioral strategies are not enough, then there are other things you're going to be dealing with that may tip that cost benefit ratio in the direction of long-term proton pump inhibitor use. So remember, it's not even only about voice. Chronic reflux can cause Barrett's esophagus and esophageal cancer, which is very difficult to successfully treat. So, reflux is a big deal for people. And if you're a singer and you've tried your best and you're looking at the difference between stopping singing or not being able to sing at a professional level anymore, or taking a proton pump inhibitor, then you're going to have to choose. So that said, there's been a lot of people I've seen on long-term PPI that haven't appeared to have suffered any particular negative consequences. On the other hand, I would always rather talk to somebody about what can we do to behaviorally control the reflux so that you don't have to take the medication. It can be a really hard sell, though. I think a lot of people, even singers, would rather take a pill than stop eating pizza. And it's just, again, so you're presenting them with, okay, here's what we know, here's what might help, what are you willing to try, things like that. In terms of weaning off, absolutely, you don't want to stop your proton pump inhibitor suddenly, because you can get what's called rebound reflux, where all of a sudden, then the body's like, it's used to sort of not having enough, and then all of a sudden it's there and it's like, woo, let's make some acid. So you do want to wean off, and often, depending on what your dose has been, they might reduce the dose and then the frequency, or perhaps, if you're on a lower dose, they may just start decreasing the frequency and then kind of wean off slowly so that your body can adapt.
Last question on reflux. What do you think about apple cider vinegar for reflux?
So I feel like I have read different pros and cons about it. Like, I've read people who say that they love it, and I've read people who can't understand what the what the actual philosophy or theory is behind it. I know it has something to do with, well, if you don't have enough acid in your stomach, that can cause the problem. I can't say that I've had enough direct experience with people who have tried it. I feel like the philosophy itself doesn't necessarily make sense to me based on what I've seen and noticed in people who have reflux. But again, I don't know everything, so this is something that I don't know enough about to say.
Thank you. Should beginner singers, teens to adults, avoid mucus-forming agents like milk, cheese, chocolates, nuts, etc.?
Yeah. My observation has been that some people get a lot of mucus from those types of foods and some people don't. And again, this is where I come back to look at yourself and your student as an individual and look at what their response is. So, for example, I have never noticed that drinking milk results in mucus after drinking it. But I do notice that if I have yogurt, I'll often have mucus after it. Why? Like they're both dairy. I don't know, but that's my personal pattern. And so I am very much by philosophy less a general rule applies to everybody person and more a, okay, these are some potential factors. How does it impact you kind of person? Because everybody's body is a little bit different. So if you notice that you get mucus after a certain kind of food, or if they do notice that, then it might be something to avoid. But if they're a person that it doesn't impact, then it doesn't impact them. And I'll also just say too, the fewer things you can give the fewer things a person has to change about their life, the more successful they're going to be. Because if we're going to be like, you have to do this and this and this and this and this and this and this, not only do they tune out, but it is, you know, if you get into the literature regarding the science of change management, you just can't change all those things at the same time. People fail at that, and then they think that they're a failure, and it just goes all kinds of wrong. I would rather say to a person, hey, here's 2 or 3 things you could do to help yourself be more successful, and have them actually be successful, than give them 10 things and say you have to do these or else, you know, all is lost.
Thank you. How do you specifically, this is a combination of 2, how do you help smokers and former smokers mitigate the effects of smoking and vaping on their voices?
Yeah, well, it becomes an ongoing discussion sometimes if I'm treating them. So that's the nice thing about seeing somebody regularly, especially if they have verbalized their desire to quit. Then we can be at the beginning and be saying, okay, hey, how'd that go this week? You know, and check in. Like anything else, with it being part of, you know, the larger body situation, you can optimize other things, optimize allergy and reflux control and other voice care. But, you know, the bottom line is their body's going to respond the way it does. And some people will eventually have vocal fold breakdown, and some people will eventually get laryngeal cancer. And so, you know, the best that I think we can do is be a guide and a resource and somebody that they can trust to talk to about the struggles that they're having in dealing with it, or the struggles that they're having in quitting. And we may not be able to help protect them against the negative impact of it. But the thing is, for a lot of people, those negative impacts don't come for a long time.
Okay. What would you say about parents of younger students when the voice teacher has asked them to refer to a laryngologist because of hoarseness that they are hearing ongoing, and they don't respond well? They say it's nothing. How might you approach this with a parent?
Yeah. So it is, you know, you can give them information, and this is my horse and water discussion, you know, at the end there, where I can give them information. What am I hearing that's different from the other students that I've worked with at this age? What is that I'm concerned about? And then what if I've seen negative consequences, well, here's what can happen if we don't address it. And again, then you have to rely on what you're comfortable with. So you have to decide then if you're comfortable continuing to give the lessons, or if then you'd have to say, well, I'm concerned enough now at this point that I feel like maybe taking lessons could be further, phonotraumatic for them, and I'm sorry I can't teach you anymore. And that's, again, it's very personal. For someone like myself who works with voice disorders every day, I have perhaps a slightly higher tolerance, but I also, again, have those medical credentials at the end where I can come to a parent and I can say, okay, most of the week I'm in a clinic, and this is what I'm seeing when people end up in the clinic instead. So I think for me, it gets a little easier even on the private studio side. And so it's a delicate conversation, one you might have to have more than once. So have you considered that? Do you have any other concerns or questions about that? And then you'll have to decide what you're comfortable with.
We are basically out of time, but we had a bunch of questions about the effect of on the vocal folds of hormonal changes, menopause, during the menstrual cycle, and also with certain hormone specific conditions like endometriosis. And maybe you could just point us to some literature on that, because I think it's a hot topic right now.
Yeah, and there have been some, and I didn't pull together some resources. I think that to really quote some literature or to give you some specific studies, I'd probably have to just look up some of the things that I've read recently, which I did read something good recently. I just have to remember where that article came from. But in general, again, I guess my theme kind of is also some individual variation. I've seen a lot of people after menopause who retain their high notes, who do quite well, and other people who they go through menopause and then suddenly a part of their range seems to have disappeared. I have definitely seen people who have monthly fluctuations in their voice function, and other people who don't. And it can be so variable, but a lot of it has to do with the fluid balance in the voice, as well as sometimes some of the general aging changes that come along with the vocal fold tissue and the cartilage and things like that. But I can try and look up a couple of things and maybe send it to Billy and Jeannie and see if I can find something that I think would be useful for you. So I'm just going to take down that note.
That would be great. Should we wrap up? Jeannie, do you want to say anything?
I do. I want to say thank you, Barbara. It was as extraordinary as I knew it would be.
Thank you.
You hit all the points. You did everything that I could have possibly imagined that I would want in a very clear way. It's so helpful because you are a singer. You get it. I want the participants, if we were in a room and we had the opportunity, we would be cheering and yelling and applauding. And so please put your hands where in a visible place and us, please.
Thank you.
We really, really, really thank you for this, Barbara.
Thank you very much. It was a great pleasure, and thank you for asking me, and I had a great time.
Wonderful. Well, we are, as I said, an international audience here, and every person who is a teacher of singing who learns more about what it is that you all do and can have an intelligent conversation with a clinician or a laryngologist or even an otorhinolaryngologist is making our profession better. It's helping teachers of singing be more professional and more disciplined and more conscious, and also maintaining appropriate boundaries, professional boundaries, so that we understand where we stop and where you begin and where there's an overlap. So we have now a break, right? And
and then everyone comes back to this main group.
Right. So after the break, Betsy will give you one more time the instructions for how you will go to the breakout. So you have break, then break out. and you will access that on your Google Classroom. After you do the breakout, then you will also have to come back at to, let's see, you have breakout, and then
break,
right?
then a break.
That's right. So you go from the breakout to a break and then come back to the main session again. Then we'll go to another breakout.
Right. So you only have a breakout with a break, and then we'll give you instructions for the second breakout, and then you'll go again. You'll have a new teacher, but the group will be together, and you'll do the second breakout. And then you have another break. And then in the afternoon, I will give you a little bit more information in the course materials and work with at least one person, maybe two. I'm also flirting with adding a session in, optional session, from 6 to 7, because there was information that I had hoped to get to yesterday, and because this is a whole new circumstance here, and we made our best guess about how it was going to flow. I would feel better if I gave it rather than not. And since today is a light day for me, I don't mind putting in a little more time. You don't have to have it. The information you got was the essence of what you needed. So it's not like, oh, something got left out and it was awful. This is like, well, it's an extra added benefit that I would put in and offer it to you if you want. And that might preclude, if you were going to do Michelle's lecture at 7 o'clock, that you'd have to eat while you watch. That's okay with me. I won't be offended. Okay? I'll see you later. Betsy, you want to tell everybody again where they have to go?
So after this little break, back at 1:15 here in the main room.
Okay, good.